I'd like to welcome you all to this evening's session on medical abortion. My name is Kath Hannon and I'm the Project Manager at the Sexual and Reproductive Health Clinical Champion Project based at the Royal Women's Hospital. I'm very proud to welcome you all to the session today. It's a combined effort across a number of organisations. Primarily, Jess Ellsworth, who is the Health Promotion Officer at WHISE, has played a key role to bring this event together. This event is part of WHISE's Metro South East strategy for sexual and reproductive health called Good Health Down South. I'd also like to acknowledge the contribution of Kathy Halmarik, practitioner of Peninsula Health, and Michelle Templeton, nurse and project lead for Monash Health in their respective sexual and reproductive hub roles. And also to the South East Metro PHN for organising and promoting the event and for the CPD points. I thank you all for your contribution. Firstly, I'd like to acknowledge the traditional owners of the lands on which we participate in the webinar this evening. In acknowledging country, I ask you to reflect on the country in which you are on today. For Paddy Moore and I in Parkville, I would like to acknowledge that this event takes place on the country of the Wurrung and the Boonwurrung people. We pay our respects to elders past, present and emerging, and extend that respect to any First Nations people who are with us today. We acknowledge that Aboriginal sovereignty has not been ceded and remains strong in their enduring connection to land and culture. I'd also like to welcome you all as participants here today. To the audience, thank you for your interest in this event and taking the opportunity to explore your role in medical abortion service delivery. We know that primary care settings and particularly GP practices are key to safe, timely and accessible care for women and pregnant people. We also know that unintended pregnancy and abortion are common experiences. Despite abortion law reform in Victoria and the availability of medical abortion procedures, numerous gaps and barriers exist that limit access and availability of medical abortion service delivery. Our intention is that this event breaks down some of those uncertainties around providing the procedure and to facilitate your role and empower you in practice. This is one of a series. There's a follow-up sessions that is targeting clinicians on the 17th of November, and the focus of that event will be on medical abortion follow-up and managing complications. And next Tuesday, the 15th at 12:30, we have also a session that is focusing on targeting practice managers. Today, just in terms of housekeeping, today's webinar, we've allocated 1 hour and 15 minutes. And just to let you know that that you can see us as speakers, and in turn as each speaker begins their presentation, they'll turn their video on. We can't see you and you can't see each other. We recommend that you use the speaker view, which means that you'll get the main image slide and a small, the presenter will be a small image. So go to your top right-hand corner to explore those options. We have a question and answer session at the end of these presentations. If you've got a question, type it into the question and answer function, and I encourage you to have a look at the any questions that other people might have uploaded and upvote them, because we will have limited time for questions and answers in the end. And also to let you know that this webinar is being recorded and it will be emailed to you in the next couple of days. And so to our speakers tonight, so the session outline is that we start with Dr. Paddy Moore, who's the Head of Abortion and Contraception Services at the Royal Women's Hospital, and she's also the Clinical Lead for the Sexual and Reproductive Health Clinical Champion Project. Next is Dr. Sarah Jess, who's a GP at Rosebud Super Clinic. Then Carolyn Mockabell, who's the Team Manager at 1800 My Options. And then I will speak. I'm Kath Hannon, Project Manager for the Clinical Champion Project. To do that. Now I'm going to stop sharing and I'm going to hand over to Dr. Patty Moore, who's my colleague in the Sexual and Reproductive Clinical Champion Project.
Thank you, Kath, and welcome to everyone. And I'd just like to reiterate Kath's enthusiasm for this evening and our excitement at the number of participants. One of the things I can see on my screen is as new people enter, I can see the clock is ticking up and we're up to 60 participants so far, which I think is overwhelming. And I want to thank you all for taking the time to show your interest in this topic. What I'm hoping to deliver in my 20 seconds is an enthusiasm amongst the audience for the possibility that you might like to pursue training, become a provider of medical abortion within primary care. You can advance the slide. So while there are challenges, I would like to argue that there are more opportunities for this to be a really democratic way of embedding good reproductive and sexual health care for women locally. If we look at our two young clinicians here in the photo, we're really trying to make this a patient-centered response. So at the point of early diagnosis of pregnancy, that women know about their choices and can make an intervention if they wish to in that pregnancy early in a timely manner without having to jump too many barriers. So tonight's talk is going to talk a little bit about the opportunities and the challenges, and I'm also going to spend quite a bit of time about the key elements in the delivery of care and how one might become a abortion care provider in general practice using early medical abortion. I think the other context is that in the time of COVID, we have all been forced to move out of our comfort zone, to do more telemedicine, to think outside of the box, and to think about ways of maintaining patient-centered care throughout the time of social distancing. So if you would like to advance the slide, thanks. So I am assuming that you are aware that there is a method of using medication to procure an early abortion. Less than 9 weeks is what it's registered for in Australia. We're also aware that surgical abortion has been available for a long time here, and that we've had abortion law reform in 2008, which enables women to request an abortion for any reason up to 24 weeks. So surgical or medical, why would we choose those? Why would a person choose one over the other? And I'm just thinking about the ideal situation versus the current climate. So in the ideal situation where a woman might have total preference over the method, the kind of things that qualitative studies have told us is that women like to decide about are their personal preference for the method, what they've heard about it, the length of the procedure, whether they could do it under their own steam, as it were, at home, or whether they had to go to clinic appointments, the length of the procedure, the number of appointments, whether they could wrap up contraception provision within the episode of care for the abortion. There might be some medical indications. Someone with a respiratory complaint who may need to avoid an anesthetic. And then also the timing and convenience. Is it more convenient to do it at home because you can have that done locally, or is it more convenient to know the day that you're having the procedure? Those would be the things that people would talk about, and particularly in outer metropolitan and regional areas, we hear women also thinking in terms of confidentiality. So in small areas where everybody knows everyone and the pharmacist happens to be also the netball coach of your daughter, you might be very, very worried about confidentiality and prefer to engage with a provider elsewhere, either on the telephone or to physically travel. So that would be an ideal Department of Human Services, publicly funded service across Victoria, and that might be my career goal, I would say. However, in the current climate, choice tends to be predicated by what is available in your region and the cost, whether you can access it publicly or whether you have to pay for it privately, the distance that you might have to travel, the time off work, and family responsibilities, and again, confidentiality issues. So we haven't quite got choice by any means, and we are now, you can advance the slide, we are now in the fortunate position that medication abortion is now available on the PBS. So after abortion law reform occurred, we had the licensing of Mifepristone and Misoprostol for early medical abortion, but it wasn't until latterly that it was available on PBS. So it is available for the price of a script. So if I'd just like to tell, I would just like to tell you a little bit about Mifepristone and what it actually is. Mifepristone was also called RU486. That was its lab name, and you may all be aware of seeing, you know, fairly inflammatory headlines about RU486, the death pill, etc., when it was first floated in the late 90s as possibly being something that Australia could look at. If you look at the first point there, you'll see that it was developed in France in the 1980s. So it's been around for a long time, and one of the things about that I always mention in my talks is that that's very reassuring. While we took a long time, and Australia really did drag its feet politically and in the medical circles as well with regard to adopting medication for an abortion, we also have the benefit of you know, those decades of experience. So many meta-analyses have happened, crossover trials, double-blind trials across Europe and Americas, showing that this is really a very safe drug. And the reproducibility of complication rates has been really very consistent. And when we talk about complications, I can be very confident in the numbers that I'm quoting you. Back to what it is, it's an anti-progestogen. Now it works on the progesterone receptors in the endometrium. Now that's a very important point. We have progesterone receptors throughout the body. They're on the ovary, they're on the tube, they're in the vagina, they're in the cervix, but it does not work on the progesterone receptors in those areas, only in the endometrium. And that's an important learning point, to realize that this methodology works for intrauterine pregnancies only. It doesn't work for ectopic pregnancies. And that becomes very important when we talk about the need for excluding the possibility of an ectopic pregnancy prior to prescribing. What it does is that it blocks the progesterone receptors, therefore interfering with placentation, and induces an abortion in approximately 60% of pregnancies less than 9 weeks. Now, if you were all in a room together with me, I'd ask you to put up your hands about what you thought about a drug that works 60% of the time. I would say, bleh, not so great. I wouldn't be taking an antibiotic that works 60% of the time. However, what was discovered was that with using misoprostol, there is a catalytic cofactor at work here, and using misoprostol, the efficacy rate rises greatly over 90%. If we stick to using medication abortion to under 9 weeks, and that's why the TGA drew the line here. If we stick to under 9 weeks, the success rate is over 95%, and that's very significant. Advance, thanks. What are the uses of Mifepristone? And I just want you to again establish that it is a very widespread drug. It's used as emergency contraception right across Europe. It's used for the induction of menses instead of using a progesterone challenge. It is not licensed for those reasons in Australia. It is also used for the induction of abortion in the first trimester, and that's what it's used for in Australia in the form of MS2 step. We do, however, in hospitals use it in the management of second trimester loss or second trimester induced abortion, and in the labour and management of fetal death in utero. So that's to emphasise to you that there is a widespread usage of it and a widespread knowledge of its profile. Advance, thanks. So in Australia, Lipipristone eligibility is monitored and mandated by the Therapeutic Goods Administration. It is mandated for use in pregnancy less than 63 days. So that's up to 9 completed weeks. 8 weeks and 6 days, it is licensed. 9 weeks and no days, it's not licensed. It is on the PBS, so it can be obtained for the price of a script. And I guess I would like to throw out to the audience to think about this, and we might talk about it in question time, that therefore it could be bulk billed. And that's one of the challenges and the opportunities of embedding it in primary care, if we can bulk bill the screening around it and the testing around it. However, the cost in private clinics remains the same or greater than that for a surgical termination of pregnancy. It does have some contraindications, and this is the combination of the mifepristone plus the misoprostol. So anyone with a bleeding disorder, an ectopic pregnancy, those in adrenal failure who are having corticosteroids administered. And that the reason for that is that the corticosteroid administration blocks the progesterone receptors, and so it's just not going to work, rather than it causing any other problem. Obviously, ectopic pregnancy, as we said before, we've got to exclude an ectopic pregnancy because it is not going to work for those patients. A bleeding disorder, you obviously don't want to have an unsupervised miscarriage in someone's home if they have a bleeding disorder. No one with porphyria is allowed to do anything, unfortunately, and an IUCD in situ is a definite contraindication. An IUCD would need to be removed before you would start the first line of medication. Hypertension, cardiac, hepatic, or liver conditions are relative contraindications, as is severe anemia. And we screen for anemia in those populations where we think they're more likely to be anemic. Advance, thanks. And so this is the general protocol. Mifepristone and misoprostol. Day 1 in the clinic, the clinician counsels the woman, takes the medical history and performs an exam and lab tests. The ultrasound really needs to be done to confirm that it's an intrauterine site and the gestational age. This is still an authority script, and when you ring up for the authority script, they ask you if you're a registered provider, and I'll tell you how to become one towards the end of the talk. And they also ask that you have confirmed to the best of your ability that this is an intrauterine pregnancy. The TGA does not tell you you have to do an ultrasound, but really it is regarded as best practice to perform that. On day 1, mifepristone is orally administered. It does not have to be observed. Some clinics prefer to observe it, but as long as the woman has the medication and is told to take it on day 1. Now, day 1 could be 3 days after she saw you because it was more convenient to do it at a weekend. But those are the sorts of things you'd want to document so that when she rings you with any issues, you know what day was day 1. Waiting 2 to 4 days is really important between the mifepristone and the misoprostol because that catalytic effect will work better if there's a delay. Misoprostol is administered on day 2 to 4, and progress towards a miscarriage is monitored with recourse to calling the clinic if need be, or calling the MS2 step helpline. This is just so that they know, the patient knows if there is a very heavy bleed that they know who to talk to. Usually, the passage of products of conception happens within 2 to 4 hours after the misoprostol is administered. Follow-up is mandatory, and this is a really important part of the TGA legislation, that the patient must have some form of follow-up within 7 to 14 days, be that a follow-up phone call or a return to the clinic. Some clinics do a repeat scan to make sure the products have passed, but in many general practices, they would do a follow-up beta HCG within 2 weeks, by 2 weeks, to make sure that it's dropping. The clinician's assessing the history for the completion of the abortion, including a clinical history, a repeat beta. And many of us, when we first start doing medical abortions, do an initial beta HCG and then a repeat in 2 weeks. After a while, you realize how much it would drop, and we're looking for a 60% drop. And after a while, we've stopped doing the initial beta HCG because we usually know how much the beta HCG would be. And it's usually a dramatic drop. If it doesn't drop and is climbing, it is a failed until proven otherwise. Thank you. Advance. The success rates, I've already said that the success rates are really good. 93 to 98% lead to a complete abortion. In the remainder, curettage is necessary to evacuate the uterus for retained products of conception. So that's around about a 2% curette rate, and that is consistent globally. What we do notice initially, though, when abortion medically is introduced either into a clinic or a set of clinicians or an area, that people, the clinicians in particular and the patients, are a little bit anxious about ongoing bleeding, and we probably notice an over curettage rate when we first introduce it. We certainly saw that at the women's until we educated all of the emergency department staff about what we would expect. The teaching point is to follow the symptoms rather than ordering an ultrasound scan, because if you over order ultrasound scans, everyone who's had bleeding for around about 7 days will have some retained fluid and or clot. Miscarriage is a process. It's not a one-day procedure, and you don't expect the bleeding pattern to be the same as for surgical. Advance, thank you. Side effects are common with misoprostol, and I'm listing them here because I'm just aware of the time, but there are side effects of miscarrying as well, and cramping and vaginal bleeding are very common with miscarriage and one has to bleed with a miscarriage. But the side effects of the drugs are from misoprostol, not from Lipipristone. It has very, very few side effects. Nausea can be the pregnancy or can be the drugs. Diarrhea, headache, and some fevers and chills are very common in most people. And so pre-medicating with antiemetics and with anti-inflammatories are really important. It's also a really important teaching point here to talk to women about how long they might bleed for, up to 9 to 13 days. And that is the most important thing that they are aware of, is that it is a longer process. Advance, thank you. Usually non-steroidals are effective for pain and bleeding. The bleeding is heavier than a period. Occasionally it's greater than 1 soak pad per hour, and that is usually when we would suggest that people seek help. We have resources to share that include a double-sided A4. On one side there are alerts for the patient, what she should be concerned about, and on the other side are instructions for an emergency department or a GP if she was to present. And so we go over that quite a lot, both in our training and in the MS two-step training. Infection is rarely severe. It's as significant as for surgical procedures, and we suggest the same screening and treatment. Advance. It is not teratogenic, the Lipipristone, but misoprostol in large doses has been associated with Moebius syndrome. Misoprostol has been used in high doses because it was initially prescribed for gastric ulcers, not for gynecological reasons. Severe bleeding requiring a curette internationally, nationally, and locally 1%, with a very low transfusion rate. But about 2 to 5% may need a curette for retained products. So this is very similar to what happens with expectant management of miscarriage. Advance. And we're getting there. This is the kind of image that we see with a vaginal scan with a beta HCG of 15,000. This is approximately 5 weeks. So this is the kind of pregnancy size that we're thinking about it being really helpful for. Can you advance? Thank you. That sac size there is approximately 1 centimeter across. This is the products of conception as passed after being washed. This was a clinic I worked in where we did a photographic study of washing the products of conception so women could see how large the sac was. Advance. Patient acceptability, approximately 90%. So the things that people like are the choice, the ability to avoid anesthesia, the privacy and the convenience. What they don't like is this prolonged bleeding. And this can be the hardest part for you as the general practitioner or the nurse practitioner who's seeing the patient or the clinic nurse, to manage that expectation that it might all be finished within a week. And I think emotionally for women, the bleeding is still the sign that the miscarriage or induced abortion is continuing. So being very realistic about what to expect, and also being able to sit on your hands literally when someone's complaining about bleeding at the 7 to 8 day mark, because most of it will improve. Timing of contraception is not perfect. A contraceptive plan can be put in place. Implanon can start on the day of the Misoprostol. There's no contraindication. Obviously, a Mirena can't be put in until you're certain that the products of conception have passed. The oral contraceptive pill can be started on the day after the Misoprostol. Advance. And advance again, because as we know, we're now just about ready to go to our next speaker, who's going to talk about the things that she found helpful when she started. But the kind of things that you need to think about as your key considerations are, you know, how you're going to run it in your service and how you're going to support yourself and your staff. So training and support of staff, having links to other colleagues that are doing this. And one of the messages I want to get across tonight is that you are now part of a community of practice. And myself and Kath will talk later about how we're planning follow-ups, how to manage complications. We have a network and a webinar system once a quarter, and we talk through cases with other providers. What the clinic needs to think about is how you're going to get the ultrasounds, having a relationship with the pharmacy. The next one I can score off. You no longer have to administer anti-D for medical abortion. So we can score that off. And I think I will do that for the next time I present. And having relationships with your local providers, most important. Advance, and this will be our last slide, how to become a prescriber. So there's one way to do that, and that's through MS two-step. Marie Stopes drug company is called Marie Stopes International. They have a website. And if you Google Marie Stopes MS two-step, it will come up, and this is the background of their website. It takes approximately 3 to 4 hours, it also monitors the prescriptions, and it also uploads and informs you of where the nearest pharmacy is. It does have an emergency 24-hour advice line for the patients, and it also is a very strong website for running repetitive webinars, education for doctors, the latest articles and review articles, videos and lectures. I would encourage you all to have a look. Unfortunately, and this is one of the weaknesses of the system, is that it is only open to medical practitioners. So nurses have to buddy up with your doctor in order to get onto the website and get the patient information, etc. But even if you're not sure that you want to get the qualification, go in and have a look at the website first. If you do get the qualification, it just means that the PBS people know that you are a registered prescriber, but it doesn't mean that you have to prescribe. But I encourage you to have a look at it. And then what we offer is ongoing training and support, because it is relatively easy to know how to prescribe the medication. What's not so easy is to sit with the patients before and after and explain the process and to be there to support them. And advance. And advance again. That's just, and so just finishing up now and thanking you for your patience. We're going to move over to Jess, who's going to talk about how she started her service, and I'm happy to take any comments at the end or questions. Thank you very much.
Thanks so much, Patty. I'd like to hand over now to Dr. Sarah Jeffs, who is a GP in Rosebud Super Clinic. Thanks, Sarah.
I'm happy to share it, Sarah. I'll bring it up.
And just to remind everyone, we do have time for questions and answers at the end. So just add your questions and we can work those out as we go.
All right, I've got it up, Sarah, so you can just unmute yourself. Hang on, I think you're still on mute, Sarah.
There we go. Thank you. Thanks, Jess. Well, thank you for the introduction, Kath, and Paddy, for your really excellent talk. And I must thank you all for attending tonight's webinar. It's nice to see some familiar names. So I hope you'll enjoy the talk and that we might inspire you to consider becoming a provider in the future. My name is Sarah Jeffs. I am a GP at the Rosebud Super Clinic on the Mornington Peninsula, and I've been working here since I moved over from the UK 8 years ago. So today I'd like to share my experience of being a provider of medical terminations in general practice and the model of care that I use. Thanks, Jess. So I'm sure most of you will have had some experience of this patient, whether you are booking them in for an appointment at reception or taking their observations or seeing them as a GP or later in the pharmacy. This woman has an unplanned and unwanted pregnancy. And as GPs, we're often the first contact for these women. We can all make a difference in these women's experience, being empathetic, non-judgmental, listening and giving her the space to ask questions. And we can all do this, whether we choose to become providers of medical terminations or not. Thanks, Jess. So I became a provider in 2018. Our GP liaison consultant, Dr. Joanna Newton, invited GPs to express an interest in providing medical terminations. And this was their strategy to broaden access for women for terminations of pregnancy in our area. The strategy being to provide medical terminations in the community, but with the support of the Early Pregnancy Assessment Service at Frankston Hospital and secondary care. Thanks, Jess. So the reasons I became a provider are that I am interested in all aspects of women's health. I've been a provider of contraception and antenatal and a provider of antenatal shared care for a number of years, and naturally wanted to include pregnancy advisory and managing unwanted pregnancies in what I could offer. Having worked in the area at that time for 6 years, I recognised the need for this service in the Peninsula. Also, I was keen to help accessibility, given that finances can be quite an inhibiting factor for many. I recognised I could provide close follow-up and reviews and felt well supported by the extended team through Peninsula Health. Thanks, Jess. So as Paddy has already discussed, so firstly, moving on to, onto the training. So from memory, I think it took 2 to 3 hours. And as Paddy mentioned, it's on this above website, the Marie Stokes MS2-step website, and it is free of charge. The next step that I took was that I met with our local pharmacist, and I asked if they would consider registering to become a registered dispenser. So they do have to get special certification for that as well, which is not onerous. And then I had a meeting with the facilitators at Peninsula Sexual Health Hub, which included Kathy Halmarick, who we've already mentioned, who's the women's health nurse practitioner at Peninsula Health. We then discussed the service in our GP practice meeting. And at this stage, it was really important to recognise individual staff members' personal views and beliefs. We were respectful of staff members' views, and we all agreed to support women getting access to appointments with me and the information that they needed. We discussed how to book women inquiring about this service in a timely and sympathetic way. And lastly, I registered as a provider with 1-800 My Options. So my contraceptive services were already openly listed with 1-800 My Options, but the medical termination services are concealed, which means that a patient would need to ring up 1-800 My Options to be given my details. Thanks, Jess. So as Paddy has obviously already mentioned too, there are some additional services that are needed. So pathology and radiology. We have pathology on site in our clinic, so can do bloods at appointments if needed. And I've listed here our local ultrasound providers. And I can give patients a full breakdown of the costs involved with those scans and the location of those clinics too. Thanks, Jess. So this is a summary of the model of care that I work on. And as you'll see, that I see patients on average 4 times. So I don't see them 4 times, I have 4 contacts with them. So the initial appointment is obviously where we meet for the first time and discuss their wishes and explore other choices. The second appointment is when I go through all the consenting and they get their prescription. And the third point of contact is I do a follow-up blood test at 7 days to check the serum HCG is dropping. And then I'll often just ring them with that result and to see how they are. And then at 2 weeks, I'll either see them or have a telephone appointment. So they're the four points of contact that we have that I have with them. Thanks, Jess. So for that initial appointment, so women may have been asked by the reception staff on booking if this is a women's health related issue and if it is urgent, in which case they will have been accommodated with an appointment to see me within 1 to 2 days. In this appointment, I'll take a full history, so pregnancy history, previous pregnancies, a sexual history, current relationships, any concerns for abuse, any risk-ish concerns, children already in their family, and I'll touch on contraception here, things that have been successful for them in the past and future contraception wishes. I also do check quite early on about the contraindications too, which again, Paddy has already mentioned, but in particular, any bleeding disorders, severe iron deficiency, adrenal insufficiency, steroid usage, etc. And again, explore all their wishes. So all of the options, make sure that they are familiar with what all their choices are, what their options are, so they can make those informed decisions. We discuss the process of MS2 step at this stage too, and how it's administered. And I also explain what one can expect in the way of pain and bleeding, and the need for supervision and for follow-up. So the next step being what investigations they may have had to date and what ones we still need to do. So we do need to do bloods, including a serum HCG, a blood group, a full blood count, ferritin. I also do a vaginal swab and an STD screen. And as we've already discussed, an ultrasound to confirm that it's an intrauterine pregnancy and the gestation. More often than not, patients come to me, or women come to me having not had these tests or still needing one or two of these tests, which I will then give them their referrals for, and we'll plan the next appointment. So the patient goes home with printed information as well at this stage, and I make the second appointment for them. I always make that as a double appointment, just because that's, again, more information giving consenting. And I'll also ring the pharmacy when they leave on that first appointment to make sure there is stock. The local pharmacist that we use, who's the registered dispenser, always keeps 2 in stock. So it would only be if there's been other providers or a lot of patients that I've seen in a short period of time that we would run out of those. But they can usually get them in within 24 hours. Thanks, Jess. So at the second appointment, again, I just touch on those patients' wishes again, and we go through any results that have come through in between appointments. I'll talk about the medications and possible side effects, which Paddy's already mentioned, and we then discuss analgesia and the timings of when to take the medications. On the MS2 Step website, you can register the patient for a text message reminder. So they get a text message reminder of when to take the second pills 36 to 48 hours later. There is also a 24/7 nurse on call number, which I always give them along with their printed information about what to expect. And I go through and do written consent. I also include a pharmacy letter with the prescription. I find it's helpful just to know exactly when it was that they administered that first tablet. So the pharmacist faxes back that letter, and then I've got a record too and an audit trail. So the scripts that the patients go away with that day are the MS2 step, which, as Paddy mentioned, is an authority script. So you ring up, you have to confirm the gestation is less than 63 days, that it's intrauterine, and that you're a registered prescriber. I also give ondansetron, and I recommend that they take it before both sets of pills. And I give a script for Panadine Fort for analgesia, but they can take Panadol and Nurofen, Nurofen alongside or Panadol instead of. If I don't have their vaginal swab back yet, then I'll give a script for metronidazole. And should the swab show BV, then I'll ring them and ask them to take that. Anti-D I've put here because we do have anti-D on site, and because I do share care maternity, I give it for that reason. It was news to me today from Paddy that we no longer need to give anti-D. Historically, we've been giving 250, a dose of 250 if they are rhesus negative. So I'll also give them a blood form for their serum HCG, which I recommend they do 7 days after the second lot of pills, and we'll plan the next appointments. Again, I don't want to swamp them with information, and I will give some information about contraception, but in a way, it's quite nice. We can do things in a more staged approach. I very rarely initiate contraception on this appointment, although you can. I tend to do that as a follow-up thing. Thanks, Jess. So to date, I've been, as I've already mentioned, the blood tests we do 7 days later, and the guide I've been using is looking for a serum HCG drop of over 80%, which I actually more often than have noticed, although Paddy had mentioned 60 is still a reasonable, drop. I tend to ring patients at this stage too, just to touch base and see how they are. And then the next appointment is at 2 weeks. If they come in, then I will do a urine pregnancy test and check that that's negative. And obviously offer support for their emotional state and future contraceptive planning. So at this stage, if they'd shown that, if they'd already explained that they're quite like an implant, I'll do this at this appointment, and certainly we can initiate oral contraceptive or depots. For IUDs, I tend to wait 4 weeks after a termination, just because I think the perforation rate is slightly higher in those first 4 weeks after. I was just going to say one other thing, just back to that one. Thanks, Jess. To date, I've been doing all of the appointments and follow-up, but having other staff members, namely practice nurses, or if you're lucky enough to have nurse practitioners in your practice, then this would be a really great way to collaborate and involve them in the service in these follow-up appointments. Thanks, Jess. So this is a reminder of the suitability for medical terminations. And in my experience, it is also the reason why women may decide to have a surgical instead of a medical. So obviously they do need to be under 9 weeks. They need to have adequate supervision by an adult who can take them to hospital if they need to at the time that they're having their pills and their abortion. The bleeding and pain for some can be quite confronting, and it's the duration of bleeding more often than not that can put them off. So this is something that is really important to counsel them about, but also respect their wishes around these things. Okay, next slide. So this is actually my second to last slide, and really just a reminder that termination of pregnancy is an important, really important service in our healthcare. It is emotive, and it's important for us to understand the feelings it might evoke in our own thoughts and beliefs, but those of our staff too. There are different ways of advertising your service as well, and it is worth considering what suits your clinic best. And lastly, I appreciate there's still much to learn in how we deliver this and how I might still improve things too. There have been a number of hiccups along the way whilst I've started my practice, and I've tried to learn from these. For instance, I've had medical termination patients booked into an antenatal appointment with me where they've been invited to see the nurse first and have their blood pressure, weight and urine checked. I've also had women attend for their dating scan or being congratulated by the sonographer. So we can't always control these things, but I have reached out to our local ultrasound providers, and I write on the forms unplanned and unwanted pregnancy, and I specify if the patient does or doesn't want to hear or see the fetal heart, because that's another thing that can be quite confronting. And lastly, thanks, Jess. So again, this is my last slide, but it was also my first slide. And the take-home message is that we can all give comfort and confidence to women facing an unplanned and unwanted pregnancy. It would be great to join together to provide a more extensive community medical termination service with the help of our gynecology colleagues in secondary care. The training isn't onerous and it is free of charge. And so I would encourage GPs to offer this. If it isn't something for them, however, then to have a good grasp of the local services and the providers. It can make such a difference to these women's experiences. So thank you for your time.
Thanks so much, Sarah. It's really useful to hear your very practical experience of setting up that procedure within your clinic, as well as some of the pitfalls in terms of what sort of things to consider, because there are a number of relationships there to consider. So I'm going to now hand over to Carolyn Mockabell, who's the team leader for 1-800 My Options. Thanks, Carolyn.
Thank you, Kath, and thanks everyone else. It's really fabulous to see so many wonderful clinicians attending this session, as well as all of the other presenters who are involved. So I want to tell you a little bit about 1-800 My Options and how we can support primary care. I'll tell you a little bit about what we do, as well as a little bit about how we can support your service. So if you could go to the, thanks, Jess. So 1-800 My Options is funded by the Victorian Government. We've been around since 2018. We are a free, confidential, pro-choice service. We have a phone line that operates from 10 till 4 p.m. And we also have a database of sexual and reproductive health services across Victoria. We provide people who call us with information about contraception, pregnancy options and sexual health, as well as pathways to trusted providers. We give non-preferential service information. So when I talk about those pathways to trusted advisors, most of our calls, around 95% of them, are women calling who are looking for an abortion service, and they want to know how on earth they find their local abortion services. We generally try to give about 3 or at least 3 services to every caller, because we want to be non-preferential. It's up to them to make the choice. And then the caller can contact all of those providers and see which one will suit them best in terms of appointment availability, cost, and any other considerations that they might have. When someone calls us, we do a very brief assessment of their needs. So we look at what service they're looking for, where they live, or where they might want to access services. We look at whether they've seen their GP and had any workup yet. A bit of basic demographics, just so that we can make sure that we're meeting their needs. And also we look at any other biopsychosocial issues that might be going on for them, whether they're experiencing any family violence, whether they've got some housing issues, for example, whether they have anything else going on. And we provide pathways to services in a non-preferential way. We also, for people who are experiencing significant hardship or have any particular issues going on, we can provide them with direct referrals through to some of the specialist services in Victoria. So could you move to the next slide, please? Thank you. So we get anywhere from 80 to 100 calls every week from Victoria. Over 70% of our callers are under 9 weeks gestation. At the moment, I can tell you that of the callers that we're having, the range varies from 15 to about 22% of our callers coming from the southeast metro area of Melbourne. At the moment, that's kind of sitting in the middle of that, although numbers are a little bit odd at the moment with COVID. So there's definitely a significant demand for medical terminations in the southeast region of Melbourne. Women's preference for MTOP, as Patty said, it's really around privacy and comfort. They don't want to go to a hospital or an abortion clinic. They see medical termination as being less invasive and also quite convenient. So if they can go to a local GP service, they don't need to travel so far. They don't need to think about childcare. And generally, it is significantly lower cost. We know that from a lot of studies that have been done, one in 2017, quite recently, 1 in 3 Australian women who were looking for a medical abortion or an abortion service found it very difficult to pay for that. Some of the barriers for women around MTOP, again, financial costs. So if somebody does call one of the bigger private providers, which are wonderful services, They might be quoted around $400 or $500 for the service, which can be quite prohibitive for a lot of people. Geographical location is another big one. We do have some regions of Victoria where there's limited availability. There's also relative invisibility of medical termination providers, including pharmacists. So women don't necessarily know that they can access it in outer suburban or regional areas. And there are also some delays that occur, a lot of misinformation in the community about medication abortion. And sometimes we do see that conscientious objection can be a significant barrier where women are not appropriately referred on to a service in their area. Thanks, Jess. So we can work with you and the sexual and reproductive health services that you offer. So we have a database of services across Victoria, and we refer women who call us to service providers on that database. Any provider of sexual and reproductive health services, whether that's abortion, contraception or other sexual health services, can register on our website to be part of the database. People can choose to be publicly listed, which means that they will be visible on our website, or privately listed, which means that people who are looking for a service would need to call us to find information. We can also do a combination of both. We can have somebody's contraceptive services publicly listed and then medication abortion services privately listed, or any other kind of combination that works for them. We can also flick that switch between public and private very easily. So sometimes a provider will want to start their registration as a private one, and then when they realise that they're not being inundated, they can manage the demand on the service, they might choose to become publicly registered. Another way that we can support primary care is if you have a patient who's looking for sexual and reproductive health services that you don't provide, you can contact us and we will most likely be able to find something that will meet the patient's needs. And you can refer your patients to call us as well. Thanks, Jess. So this is just a picture of the front page of our website. I thought it was really useful to be able to show you how to use it. I've circled the for health professionals section at the top in blue. It's circled in a red circle. And that for health professionals is where you go if you want to register your sexual and reproductive health services, whether that's contraception, abortion or sexual health. If you want to find a provider for services for one of your patients, you can search for healthcare services where the other circle is, and that will open up a map of services across Victoria where you can filter for different types of whether somebody is looking for a copper or a hormonal IUD, whether somebody is looking for implant on insertion, whether someone's looking for medication abortion or surgical abortion. Thanks, Jess. So here are some contact details for us, but I really want to remind you that the numbers for abortion in Australia are around 1 in 4 women or 1 in 3 women in their lifetime will have an abortion. It's a really important part of primary care, and there are so many supports around to support GPs and other people in primary care to really make sure that we can meet the needs of the women that are seeking these services. Thank you.
So much, Caroline. Just give me one moment. I'm going to get my PowerPoint up. Thanks for that, Caroline. It's a very important part of the service delivery, having 1-800 My Options. I'm going to get to the, sorry, I've just realised. Uh-oh. One I'm after, and sorry about that. So I'm Kath Hannon, and I am part of the Sexual and Reproductive Health Clinical Champion Network, and I'm just going to talk really briefly, because we're behind time, around what the Clinical Champion project is around. My colleague is Dr. Patty Moore, who's the clinical lead, and broadly our role is around providing resources and support to the sexual and reproductive health workforce to build capacity to offer evidence-based abortion and contraception, or LARC, in particular LARC services. So the work we do is around building clinician knowledge, skills, and to provide opportunities for ongoing support to increase clinicians' capacity. There's a couple of core activities that are involved in the Clinical Champion project. The first one I'll point out is policy guidelines, procedures. So the Women's, as a key provider of publicly funded abortion and contraception services, have a number of policy guideline procedures to guide our practice. And through this project, we are making them more relevant and accessible to an audience external to the Women's. To date, we have published just one. Our PGP on medical abortion is available on the Women's Health website, and so that's available to the public. Others are in development. We have one coming on board soon around assessment and care, and the managing complications post-procedure PGP is available directly from me at this stage, but eventually in the very near future these will be available on our website. There's a range of other resources too, and because they're not currently available on our website, I encourage you to contact me directly. My contact details will follow. For some time, the Women's have been doing education and training in long-acting reversible contraception, both Implanon and IUD. And unfortunately, both of these programs have been heavily impacted by COVID. In terms of Implanon, the Women's provide the practical training workshop, which is a part of the training, the suite of training for Implanon providers. In the near future, we will advertise our practical training. It will be available virtually. But if you're interested, again, email me directly and I can set this up. For IUDs, if you're a GP who's had some training in IUD insertion, but say your practice has lapsed or you just want an opportunity to refresh and build your confidence, there's a process where you apply to come to the Women's to be part of the IUD procedure clinic to be trained up. But again, during COVID restrictions, that opportunity is not available. But if you're interested, let me know and we can put you on the waiting list. In terms of clinical leadership of the sexual and reproductive health workforce, Paddy's the clinical lead, and we partner really closely with both 1-800-MY-OPTIONS and another organisation called the Centre for Excellence in Rural Sexual Health, or CERSH, and we provide community of practice forums for ongoing clinical support. And the networks are that first one there, the Clinical Network for Unintended Pregnancy and Abortion, is Paddy alluded to that earlier. It's a quarterly forum, and there's in the next slide there's a link for the around how to register. We partner with CERSH and 1-800 to produce a quarterly newsletter, and that's another opportunity to connect with the community of providers. And just wanted to highlight the resources that are available on the CERSH website. Unfortunately, the MS two-step is just available for the medical community and pharmacists. There's nothing that nurses can currently independently access, but part of the Clinical Champion project, we're working on that. But in the meantime, CERSH have got some really important resources, either e-learning modules. They have now a suite of 12 modules across a range of sexual and reproductive health topics, and one of those topics is medical abortion. And CERSH also facilitate a resource hub, which is all the policies and templates and tools that you might need to provide medical abortion. And I'll just note that these are my contact details, and CERSH website is there too. And I just encourage, I've got some resources, either PGPs or other resources to support practice. So I just encourage you to send me an email and I can forward those directly to you. All right, I'm going to stop sharing now and get back to Q&A.
I can bring it up, Kath.
Yeah, thanks. So we've had more questions since I've been talking, but just to get back to our Q&A in the time that we've got left, I'll just start with you, Patty. This first one was a clinical question around someone who is on antihypertensives and but where their BP is under control. Are there any contraindications to MS two-step?
That's an excellent question, and one that we probably face quite commonly. And the answer is no. If your blood pressure is under control, that is not a contraindication. And we would suggest that everybody continues with their usual medication when they're going through a medical abortion.
Thank you, Patty. Another question probably for you, Patty. Is there any way of determining who is more likely to fail the medical abortion procedure or where it's not successful and need a curette?
And I think another question later is it more likely that they'll fail the closer they get to 9 weeks? So the failure rate is slightly higher after 7 weeks, but not statistically significant. There's no actual test of who's going to fail, but certainly the earlier the gestation, the much more likely they're going to have an easier time of it. Some useful screening tests are to ask people if they have heavy or painful periods, if they've had miscarriages before, what their experience was, and how they cope with the miscarriage. And so somebody who's got severe endometriosis and requires quite heavy duty medications for their period is going to experience problems with pain control possibly. So there's a way of assessing who might be a good candidate in terms of how they're going to cope and what their expectations are, but there isn't a magic test, unfortunately, of who's more likely to fail. But I think the most important reassuring thing is that, you know, the failure rate is between 2 and 5%. Just a comment on the failure rate. Sorry, you've started me off, Kath. Now you have to shut me up in a sec. Is that quite often there is a conflation in clinicians' minds between retained products and failed medical abortion. A failed medical abortion is at a rate of 1%, and that is an ongoing pregnancy. And that's the one we've really got to make sure we follow up, you know, that we don't miss that. But the rate of retained products of conception is greater than that. So retained products of conception of themselves is not a failed abortion. It's retained products. So I just want to make that distinction.
Yes, and it's a very important distinction. It's a very important distinction too. Thanks, Patty. There were questions for you too, Sarah, just around your clinical setup and how you arrange your clinical diary or schedule so that you are able to provide timely appointments for people who are requesting a service.
Yeah, I saw that question from Nicole. Thank you, Nicole. It's a really good question, and we thought long and hard about how to make this availability in the clinic. Because it's quite ad hoc when I might be requested to see someone for a medical termination, then we haven't necessarily ring-fenced a time in each day or each week for that. And also it was very dependent on what the woman decided to share with the receptionist when booking the appointment. So that's why we decided just to come up with these 2 quite simple questions. Is this a women's health related issue, and is it urgent? And I would hope that they would say yes to those 2 things. And then we would more often than not just get them into a single appointment with me, and with the knowledge that I was more often than not needing to send them on to have another test done. So that's how we've been able to get women in quickly. But it is quite a tight appointment for that initial one, and then we can plan the next one with a bit more time. Have I answered the question?
Thanks, Sarah. You might like to respond to this question too, because it's around follow-up. And both you and Patty talked about either a 60 or 80% drop between day 7 and day 14 for the beta HCG. And what's your experience about people attending for follow-up, and what's your process around follow-up? People say who are hard to contact or non-contactable. If you just want to talk what your experience is there.
Just seen Nicole's reply. So it's actually been made a lot easier with telehealth, because some women who have travelled from some distance find it a lot easier to maintain that follow-up over the phone. I will always book those 2 follow-up appointments with them in my room. So they leave with the appointment, with the time, with the day that they'll expect a phone call or that they'll be coming in. There's been 2 patients, I think, in the last 2 years that I've been doing this who refused to attend follow-up. And they sadly were quite complex patients with quite extensive drug habits and social issues, and they didn't come back for their follow-up at all. And I don't think I even managed to get hold of them on their phone. I did see one of them months later and she told me everything was fine. But
if I'll stay with you, Sarah, if you don't mind. There's a question there about the BV swab that you do. Is that an opportunistic screen, or is BV associated with a higher risk of complications with medical abortion?
Yes, I've just adopted that as part of my routine. A lot of my training too came from doing the family planning certificate, and they do it as a routine before medical terminations for the risk of endometritis. So by treating any confirmed BV, minimising that chance.
Thanks, Sarah. I'm jumping around the place here a bit, but I'm just wondering if maybe Patty might like to talk about consent. There's a question here about the lower upper age limit for a medical abortion procedure. Would you like to make a comment on that, Patty?
Sorry, lower and upper limit?
Yeah, age limit, but around consent.
And someone's too old to consent? Maybe that's me. The issue of consent is the same as consent for anything. So in Australia, we do not have to have a lower age limit for consent for a prescription for contraception. And as long as you can demonstrate that a minor, a patient who's under 18, has demonstrated that they understand the method, they understand the implications of not having the procedure, they understand the implications of having it, and you document that and that you feel that they've understood and that they understand what's in their best interests, they can be deemed competent. So my gained wisdom about that over the years, having worked with a lot of adolescents, is that the younger the patient, the more I tend to write about what their understanding was, but there is no lower limit as such. Does that answer the question?
I hope so. We can't see any nods or any interaction, so we're just shooting blind, really, aren't we? So another.
Because that came up.
So, say that again, Patty.
Should I talk about the anti-D, because Sarah and I?
Yes.
Yeah. Okay. So somebody said, well, what should you do? So the reason I actually had it up there and then said I'm going to cross it out soon is that over the last 5 to 8 years, there's been a consistent amount of research done about whether or not early medical abortion is a immunizing procedure. And during that time, people have moved away from using anti-D for the medical management of miscarriage and for the medical management of early medical abortion. And across Europe and the Northern America, it is now no longer regarded as mandatory. The Royal College of ONG and then followed by RANSCOG have have put out a guideline that we no longer need to prescribe anti-D for early medical abortion up to 9 weeks. So the catalyst for that was COVID-19. We had put in an application for the college to review its guidelines, and they were being rather slow. And then once COVID hit, the whole issue of that being an extra barrier for women meant that they got onto that promptly. So you do not have to prescribe it. And that's something that we're now having to message quite widely, because a lot of GPs will be concerned and send their patient to an emergency department to receive anti-D, which in of itself at the moment is not a really good place to be going. For those who are still really nervous about it, you will do the patient no harm, but you're putting another thing in that they have to do. So that's where we're up to with anti-D.
Thank you, Patty. And you can actually go to the RANZCOG website. If you just Google RANZCOG anti-D COVID, you'll come up with the page on their website that outlines their statement. Patty, perhaps another one for you. Are there points of differentiation between a nulliparous and a multi-women with in regard to medical abortion?
And the answer is not particularly. And there's no major contraindication. So if a woman's had a Caesar, it's not a contraindication. The only difference might be in that you've got a little bit more experience in the multiparous patient to hear about how did they manage their labor, what happened, did they have a spontaneous vaginal delivery, did they have a PPH, you know, all of those sorts of things. That's maybe you know, a point of history with the patient rather than a point of difference.
Thanks, Patty. I'm just aware, probably just got time for one more question. There's a question there about ultrasound. Do you want to just talk about what you're looking for at ultrasound?
Yep. So if we remember the slide that I put up, I should have mentioned that at that point, that what we're looking for is a gestational sac with a little yolk sac inside it, which is the second stage of intrauterine gestational development. So you can get an ectopic pregnancy with a funny little sac called a pseudo sac. And that's not an intrauterine pregnancy. But once you see a yolk sac within the gestational sac, as I showed in my illustration, that appears at 5 weeks, and that shows that it's intrauterine. So the answer to the question is you don't have to wait for 6 weeks. And we've had sort of some unusual things happen as a medical abortion was rolled out across Australia, that some practitioners thought you had to wait till there was a fetal heart before you could do an early medical abortion. And really, when you think about that, it's counterintuitive. The idea of it and the promise of it is that you can do this procedure at 5 weeks once you know it's intrauterine. And very quickly, the one above, do you have to follow the beta HCG to 0? And the answer is a resounding no, you do not. It's really, you're looking for that decrease. It's not an ectopic. You do not have to chase it to 0. And beta HCGs take a long time to get to 0. A lot of women are menstruating with their next period with a beta HCG in the 30s. So there's no need to follow it.
Thanks, Patty. I just encourage people to have a look at the policy guideline procedure on the women's website about medical abortion, because this really will answer quite a number of these questions that are coming up. And also a reminder, Kathy Halmarick, who is your local nurse practitioner at Peninsula Health, is reminding you that there is an IUD clinic at Peninsula Health, and on the chat she's put in her phone number. And if you wanted to, if another way of making contact with Kathy, with is through me and my email address.
And if I could just really quickly interrupt and shout out to Kathy, because I'm seeing her question here. Do I envisage a time when nurse practitioners will be able to deliver MS2 step? I'm not going to retire until they can. I'm advocating really strongly for that to happen. And you can imagine, and we can have a talk about this sometime, the kind of kickback against that. You know, be the thin end of the wedge, etc., etc. But this is a process that can be administered by nurses. The NHS runs its service on nurse power, and they prescribe. So to be continued, Kathy.
That's right, there's lots of evidence for nurse-led models of care. Look, we've reached time. We better wrap it up. Thank you for everyone's attendance today, being part of the session. Thanks for sharing your expertise, Paddy, Sarah and Carolyn. And just a reminder that there is a follow-up session on November the 17th, where we'll be talking a bit more around follow-up and managing complications, and the session next week for practice managers. I encourage everyone to fill in the evaluation, and if you would like to make contact either with Jess or Jess or myself, our details are on the screen. Thanks so much everyone for your participation tonight. Good night, go safe.